Okay, today we are going to talk on some of the picture tutorials that um, are relevant in your exams. Now, I'll be emphasizing some of the pathologies that are very important that you may see in the exams. All the slides are important, but there are some that unfailingly you might see them featuring, especially in the picture tests. Those that do not feature may you may see them in the MCQs. So one of the essence of this is for you to have a revision material. Even after the lectures, you can still go over it again and watch what we've discussed. Okay, so the first condition we are looking at here is jaundice. Okay, if you look at this picture, the patient here has yellowish discoloration of the eyes. And yellowish discoloration of the eyes is called jaundice. You can see this whitish part of the eye can become yellowish or greenish, as some may say. So that is called jaundice. Once you see a patient with jaundice, of course, you know it is bilirubin that is deposited. Now, this bilirubin that is deposited may come from a liver pathology or a non-liver pathology. That means the cause may be intrahepatic or extrahepatic. Okay. Now, the causes of jaundice could be prehepatic before the liver. Since the liver is used as your reference point now, okay, it could be prehepatic, intrahepatic, okay, or post-hepatic. Now, when you say prehepatic, before it gets to the liver, you have bilirubin liberated in the bloodstream. So the cause is before red blood cells enter the liver, you have lysis, especially in patients with hemoglobinopathies. You see patients that are sickle cell disease, patients with sicklers, the ones you call HBSS, they have yellowish discoloration of their eyes, or patients with thalassemias, they have yellowish discoloration of their eyes. So that is a prehepatic jaundice. The jaundice is not caused from lysis of the cell or liberation of hemoglobin in the liver. It is caused by the lysis of the abnormal red blood cells. And these lead to deposition of bilirubin in the sclera and mucous membrane and under the skin. So it will give them all these features. Then you have intrahepatic cause of jaundice, like patient with hepatocellular carcinoma, patient with liver pathology, where you have abnormal conjugation of bilirubin. Then you have post-hepatic, usually, or you call this extrahepatic or post-hepatic. This is due to obstruction of the drainage of the bile that is being formed in patients with obstructive jaundice. Okay, mostly post-hepatic jaundice and intrahepatic jaundice are surgical jaundice. They are caused by surgical pathologies like stone or obstruction, okay? Maybe biliary hepatocellular or hepatobiliary tumors, okay? Now, the types of jaundice, you can classify jaundice as conjugated or unconjugated. Now, when you say conjugated, it means the bilirubin has been transported to the liver by plasma protein, albumin, and it has combined with glucuronic acid to become soluble. That is a conjugated bilirubin. While unconjugated bilirubin are the ones that are liberated from lysed cells, they are not soluble, okay? So that is the difference. Conjugated bilirubin are the bilirubin that are being combined with glucuronic acid in the liver. That is catalyzed by uridyl diphosphate glucuronal transferase. That is the enzyme that catalyzes the reaction. And the essence of that is to make the bilirubin soluble. So conjugated bilirubin are soluble bilirubin. Unconjugated are insoluble ones. So when you have patients with jaundice, how do they present? The presentation actually depends on the cause of the jaundice. You may see patients presenting with the symptoms of the underlying cause of that jaundice. If a patient is a sickle cell disease patient, you will have all the manifestation of sickle cell disease or sickle cell anemia. You should know all those ones. If the jaundice is as a result of liver disease, you will see all the clinical features of liver disease. If it's from stone, if it is from tumor. Now, if it is a post-hepatic jaundice, whatsoever the cause may be, obstructive jaundice has some certain clinical features like pale stool, generalized body itching, passage of dark urine, okay? They have a pale, bulky stool that is difficult to flush because a lot of fat, you see, when they pass stool, there is a lot of fat in the stool and it is whitish. They can't flush the stool because of the fat. So that is obstructive jaundice, whatsoever the cause may be, okay? So how do you investigate patients with jaundice? You do a liver function test. Liver function test. Now, the liver function test has some certain features. One, liver enzymes. The component, liver enzymes. Okay, these liver enzymes are what? AST, ALT, ALP. I hope you know all what they mean. Then the albumin, globulin, then bilirubin, and in the bilirubin now, you now look at the conjugated and the unconjugated. Okay, so these are some of the components of liver function test. Now, we are going to talk about liver function test separately, not in this particular slide. It's just to tell you that it's a broad aspect of your exams. Now, your slide on the picture test could just be on liver function test alone, for you to interpret the liver function test and give the likely diagnosis the patient has. So if you look at all the parameters, if it is obstructive jaundice, you know. If it is from hepatitis, if from some other causes, you will be suspecting based on the derangements you have. Okay, if a patient has jaundice, any patient you see with yellowish discoloration of the eye, you must screen that patient for hepatitis, okay? Because hepatitis is a common cause of jaundice. Now, hepatitis B and C are the most medically important hepatitis because they can transform into cancer, hepatocellular carcinoma. So you see, just indiscriminate use of sharps. You just see all the people that are cutting nails on the street. You just go and cut your nails. You can contract hepatitis. all these traditional birth attendants, they are cutting umbilicals in babies. They transmit hepatitis. And the danger of hepatitis is they can stay on a sharp object for up to 6 months, not unlike HIV that doesn't last for more than 5 minutes. Okay. You see in local areas, they will line up children and doing circumcision with one blade. If you go to villages, you see the line 20 children next, they will just cut off the pupils. And you imagine how many children have been infected from day one with hepatitis. It's a very significant cause of morbidity in the population. Now, if you go to developed countries, you'll find out that hepatocellular carcinoma is most of the cause of chronic liver disease there is from alcohol. While in developing countries like ours, most of the causes of those is from hepatitis because they have eliminated the hepatitis. They don't have the issue of hepatitis in those developed countries because of screening and vaccination. Okay. In developed countries, they don't have problem with all these diseases that can be vaccinated, that have immunization. Their problem is not similar to developing countries where most of our problems revolve around malnutrition, poverty, and disease transmission. So you have to do all the viral markers for hepatitis. Then ultrasound scan, you scan the liver and you scan the hepatobiliary tract. Okay, the liver for features of chronic liver disease and the hepatobiliary tract for any form of obstructive jaundice. That is the role of ultrasound scan. Now, who can tell me the role of urinalysis in jaundice? So unmute your mic and participate. What is the role of urinalysis in a patient with jaundice? Yes, Aisha, Hadi. Unmute your mic and tell us. Urinalysis. Are you?
Okay. Patient with jaundice.
Yes, a patient with jaundice, you do urinalysis. What are you looking for? You know what urinalysis is?
Yep.
What is urinalysis? Let's start from there.
It is an investigation done with urine sample.
Yes.
To identify any abnormalities in the constituents of
abnormality. Which type of abnormalities? Yes, Abdullahi, Rabiu. Aisha says she doesn't know. Tell us, what is urinalysis? Are you there? Where is Abdullahi? Tell us about urinalysis. And now your network is not good, Ko. Tell us. Okay, Abdullahi doesn't know urinalysis. Fatima Ahmed.
Yes, sir.
Tell us about urinalysis. What is the role of urinalysis in jaundice evaluation?
The sir is to check for the bilirubin.
Yes.
And the orobiliary. I don't know how to pronounce it. The other name.
I can't hear you clearly. Can you hear me?
Yes, sir.
So speak clearly.
Sir, to check for the bilirubin.
Yes.
If it is
that is correct.
And to check for Bilinogen.
Yes. So when a patient has jaundice, one of the simple bedside investigation you do is urinalysis. That is urine analysis. Urinalysis means urine analysis. And when the first thing you do, you look at the physical appearance of the urine. What is the color? The normal color of urine is amber color. So you look at the color. Is it amber color or is it yellowish? If it is yellowish, okay, or darkish, you know there is bilirubin in it. Two, is it frothy? That is foamy. You shake the urine in the collecting tube. If it is frothy, you know there is bilirubin in it. Then the next thing you do, you dip stick. There's a stick. Okay, the urinalysis is done using a dipstick. I know if you see it, you see the dipstick when we are doing describing investigation and interpretation of results. It has different colors, different bands of colors, and each indicates what you are assessing. If it is positive in that urine, there will be a change in color, indicating that element is present in the urine. Okay? If there's bilirubin, that band that is coded for bilirubin will change. The color will change. Do you understand? So now, that is some basic investigations you need to know. Any patient with jaundice, don't forget, do urinalysis, do ultrasound scan, do viral marker, do liver function tests. Okay, then other investigations will depend on the underlying cause of the disease. Now, the treatment depends on the underlying cause of the jaundice, because all jaundice is just a sign of a particular illness. It's not a diagnosis per se. Okay, the complication of jaundice, okay, you have several complications, which could include hepatorenal syndrome, okay, when you have deposition of bile salt, bilirubin in the renal tubules, you can have that. Okay, you can have deposition on the central nervous system. You can have deposition in some tissues. You can have biliary cirrhosis and so on. Okay, so any question? Any question before we continue?
No, sir.
Okay, we are going to proceed. Now look at the next image. This image shows finger clubbing. If you look at this, you can see this is an image of a drumstick appearance of the digits of this patient. Now you can see this digital clubbing. And digital clubbing is swelling of the distal part of the fingers and toes. Now, the exact mechanism for this is not known, but usually they are associated with chronic diseases. Chronic diseases. The exact mechanisms are not known, but they are usually associated with chronic diseases. And of course, they are in stages. Now, the first stage, there is increased sponginess of the nail fold. When you touch, if this is the finger, okay, and this is the nail, there will be increased fluctuancy of this area. This place is called the nail fold. When you palpate, it will be soft and fluctuant. That is stage one. Then stage two is obliteration of the angle between the nail and the nail fold. Okay, if you now look at the finger at this view from the lateral view. Now, this is the nail fold, and this is the nail bed. So there will be there's an angle of about 15 degrees here. So when you have obliteration of that angle, it becomes flat, okay? There is no angulation between the nail fold and the nail bed. That is stage 2 of finger clubbing. Now, stage 3 or grade 3 is increased convexity of the nail longitudinally and transversely, okay? You can see what will happen is there will be increased convexity. The nail, it won't appear drumstick like this one, which is stage 4, but the convexity of the entire nail will increase longitudinally and transversely. And stage 4, bulbous swelling of the distal end of the finger, just like a drumstick. It is called drumstick appearance. And stage 5 is osteoarthropathy, because that is seen on X-ray, not as a clinical manifestation. Now, I told you finger clubbing is a disease, it's a condition, it's not a disease per se, it's a clinical sign that is picked commonly in chronic diseases. Now, various systems might be involved. The respiratory system, patient with bronchial carcinoma, chronic interstitial lung disease, cystic fibrosis, lung abscess, fibrosing alveolitis. Cardiovascular disease, you could have cyanotic congenital heart disease, bacterial infective endocarditis, severe chronic cyanosis. Gastrointestinal diseases like liver cirrhosis, ulcerative colitis, Crohn's disease, celiac disease. Endocrine hyperthyroidism, you see, okay, thyroid arthropathy. Others could be familial. This is harmless and frequently asymmetrical. Now, there are some patients that may present, and when you examine them, you see a finger clubbing and they tell you it runs in the family. So in those types, they are not associated with any form of systemic disease. Now, the treatment actually depends on the underlying cause. Okay, any question? Any question? Are we together?
Yes, sir, we're together.
So any question? Or can we proceed?
We can proceed.
Okay. Now, this picture here shows a patient presenting with angular stomatitis. By this edge of the mouth, you see some ulceration. Commonly, which kind of people you see? This is malnourished. You see all these almajiris, they will be having some ulceration at the edge of their lips. That is called angular stomatitis. This is commonly associated with malnutrition, immunosuppression. And what is the cause? It's infection. It's fungal infection that is complicated by bacterial infection. So it's a subset of erythematous candidiasis, a lesion affecting the angles of the mouth, causing inflammation and fissuring. And as they open their mouth wide, it tears more and they can have bleeding there. So it is both a candida and bacterial infection, especially Staph aureus may be involved. What are the risks in patients presenting with angular stomatitis? Patient with denture-related stomatitis, poor oral hygiene. Okay, poor oral hygiene can be associated with that. Crohn's disease, vitamin B12 or iron deficiency, immune defects such as diabetes mellitus, HIV, patients on chemotherapy, patients that use drugs, steroids, can have that. Okay, so you should know, basically, if you see this in your exams, you should be thinking about malnutrition-related diseases or immunosuppressive-related disease. Don't forget, it's combination of both fungal and bacterial infection. How is it treated? You treat the underlying cause. You can't be treating the angular stomatitis in the malnourished. You've not given the child food. You are treating angular. You have to correct the immunodeficiency first. And you have to improve oral hygiene. If patient has a poor oral hygiene, you have to improve the poor oral hygiene in the patient. Okay? Then you give zinc oxide by applying zinc oxide. It's a cream. You apply it at the edge of the mouth, and you can use topical antifungal or antibacterial agents. So when you spot this picture, what comes to your mind? 1, angular stomatitis. 2, malnutrition. 3, immunosuppression. 4, combination of bacterial and fungal infection. Now, this other picture here, you can see some milky whitish plaques in the gum and the tongue of this patient. This is called oral thrush, and it is caused by Candida albicans. Candida albicans, they are normal flora of the mouth. The mouth has the highest number of bacteria, but of course, because of your immunocompetence, they are harmless. If a patient becomes immunosuppressive, these albicans, Candida albicans, may now produce infection there by penetrating the gum. That's why if you scrape it off, it will be bleeding because it's invading the mucosa there. So they present as plaques resembling milk cod seen on the tongue and oral mucosa. When removed, reveals a raw erythematous or blood bleeding base. What is the risk in a debilitating patient that are very sick, patients that have been very sick for a very long time, patients on steroid, corticosteroid? Mark you, steroid is a drug that reduces immunity in a patient. And when immunity in a patient is reduced, that is, all those cells that can fight infection are suppressed when patient is taking steroid. And of course, a lot of conditions can manifest. All the clinical features of abuse of steroids will appear. Okay, so broad spectrum antibiotics. When patients abuse antibiotics for a very long time, they can now kill some of the protective flora in their body, and they can come up with oral thrush. Or patients that are on chemotherapy, cytotoxic drug for cancers, it can cause immunosuppression because it kills some cells that defend the immunity of the patients. Now, how is it treated? If the oral thrush is mild to moderate, you can use nystatin suspension. They are prescribed as drops. Okay, they are solution in a container that are prescribed as drops. So you just give like 4 to 5 drops TDS. Now, if it is moderate to severe, you use tablet, fluconazole tablet. Now, chlorhexidine oral rinse is an antiseptic that is used as mouthwash. You can use chlorhexidine mouthwash to rinse the mouth morning and evening, okay, or in the mornings. Okay, it has some antiseptic property. Now you disinfect dentures along the antifungal therapy. So most of all these things we are showing today in the mouth are related to immunosuppression. Okay. Now this next image is showing rheumatoid arthritis. Now let me draw your attention to this. What you can see in this image, that is a giveaway. If you see this in your exam, what is a giveaway in this is this shape. You can see the shape of this finger, okay? It is called swan neck deformity. Swan neck, you know swan, I believe you know swan, okay? So the finger appears like a swan neck deformity. So rheumatoid arthritis is an autoimmune condition. When you say autoimmune, the immunity identified, there are some substances, okay, that are produced by the immune system of the body that will now identify some part or tissues in the body as a threat. They will now attack that tissue. So that is what an autoimmune disease is. Okay? Now, rheumatoid arthritis is a chronic multi-system disease of unknown etiology characterized by persistent inflammatory synovitis. Okay, so now the autoimmune, the antibodies that are produced are attacking the synovial membrane, usually involving peripheral joints symmetrically. Don't forget. Involvement of joints in rheumatoid arthritis are symmetrical with systemic disturbance and extra-articular manifestation. Now, you should know rheumatoid arthritis, unlike other forms of arthritis, don't forget, has extra-articular manifestation. They affect all other systems aside the joints. Okay, now the main cause is unknown, but it's autoimmune related to HLA-DR4. It's a type of immune cell. Now, there are both genetic and environmental factors that play a role in the pathogenesis of rheumatoid arthritis. What are the risk factors? Now, it is 3 times commoner in females than in males, and the age occur in young individual up to the middle age. 3 times commoner in females than males, and it occur in the young and middle age. It is autoimmune and it could be associated with cigarette smoking. It could be associated with what? Cigarette smoking. Now, how do they present? They present with joint stiffness, tenderness, pain on movement of the joint. When you move the joint, there's pain. There's swelling and deformity. We talked about the swan neck deformity or Botonia's sign or hammer toes. There's joint ankylosis, rheumatoid nodules, carpal tunnel syndrome, then extra-articular manifestation. Now, this extra-articular manifestation, I said it could affect any of the system, okay? Any of the system. It could affect the hearts presenting with cardiomyopathies. It could affect the lungs. It could, all the systems could be affected. That's why they have some form of extra-articular manifestation. Now, how do you investigate them? Okay. Now, the investigation you do anti-nuclear antibody profile, rheumatoid factor assay, then you do X-ray. X-ray showing the joint deformities. Usually, the joint deformities you find is reduction of the species of the joints, okay? And you could have a lot of erosions of the joint that you see on X-ray, okay? Then the ESR, C-reactive protein, will all be elevated. ESR, C-reactive protein will all be elevated. Okay. Now, how is it treated? Now, you should know one of the most important presentation of all these arthritis is pain. Okay, pain. So what you give is analgesics. So the treatments could be classified as non-pharmacological, that is non-drug treatment and drug treatment. The non-pharmacological treatment include rest. One of the most important treatment for joint pain is resting that joint. Okay? Resting that joint. Now, because of course the articular surfaces are eroded and there's a lot of inflammation, as the joints rub one another, it worsens the wearing off of that joint. Okay, and patient will have pain. Then you have physiotherapy or exercise of the muscle around the joint so that you have relaxation and relief of the stiffness of the joint. Then hot bath, you can do warm compression so that blood flow will increase and the inflammation will reduce. Application of cold splints to reduce pain. Okay, application of cold, then use splints. There's splints. Splints are devices that you use to reduce movement of the joint. And of course, weight loss, because if you are losing weight, the amount of load on that joint will reduce and the inflammation will eventually subside. Okay. Now, the pharmacological treatment will include the use of NSAIDs, low-dose corticosteroid, okay, disease-modifying anti-rheumatoid drugs, and immunosuppressive drugs. Now, if there are some constitutional extra-articular symptoms, they have to also be tackled because patients could present with eye problems like drying of the eyes. You could apply some artificial tears. Okay, they could have interstitial disease of the lung, pleural effusion. They could have pericarditis where you have to treat. They could present with also anemia where you need to treat anemia. There's what is called Feltis syndrome. Patients with rheumatoid arthritis can present with what is called Feltis syndrome. Feltis syndrome, they have rheumatoid arthritis, splenomegaly, and what do you call it? Neutropenia. The splenomegaly will be wiping up the cells. They could also have peripheral neuropathy as extra articular manifestation. Okay, so many extra article, even muscle pain and muscle weakness. Okay, so don't forget, if you see rheumatoid arthritis, always remember number one, it is an autoimmune disease. Number two, it is 3 times commoner in females than male. Number three, okay, it is common in patients with cigarette smoking. The deformity is what symmetrical, affecting joint symmetrically, and they have the swan neck deformity, okay? And they also have extra articular manifestations of the disease. Investigations, we mentioned them, okay? Now, osteoarthritis now. Now, the difference here in osteoarthritis, it's not an autoimmune disease, it's a degenerative disease seen in more older people compared to rheumatoid arthritis that is seen in a more younger people. Okay, now, one of the similarities between osteoarthritis and rheumatoid arthritis is that the onset is gradual. It's something that will occur gradually. Okay, it's not sudden in onset as in the others we'll see shortly. But you should know that osteoarthritis occur in more older people, people that are more than 50 years, while rheumatoid arthritis occur in younger people, and it is autoimmune in cause. Now, for osteoarthritis, because it's a degenerative disease, the female-male ratio is the same, unlike rheumatoid arthritis that is 3 times commoner in females than male. So osteoarthritis presents with pain, typically in the knees, hip, spine, and hands. No extra articular features and no systemic illness. This is a very important differentiating factor between osteoarthritis and rheumatoid arthritis. Don't forget, osteoarthritis is a degenerative disease. Rheumatoid arthritis is an autoimmune disease. Now, they have morning stiffness, okay? Now, when they wake up in the morning, okay, they will have some form of stiffness of the joints. Now, this stiffness is, you can also see this stiffness in rheumatoid arthritis. Okay, they could have stiffness. Okay, what are the signs? There's joint swelling, crepitus. As they move the joint, they will be hearing sounds, crepitus sound in the joint. There's muscle wasting, joint deformity. If you look at the hands, there's what is called Haberdin's nodule. Haberdin's nodule. Remember rheumatoid arthritis, swan neck deformity, osteoarthritis, Haberdin's nodule. What is the Haberdin nodule? You have bony swelling in the distal, okay, distal interphalangeal joints of the finger. You can see them. You can see them. They are called what? Haberdin's nodule. Then you have Bouchard's nodule. Bouchard's nodule. There are nodules at the proximal interphalangeal joints. So you have Bouchard's nodules and Haberdin's nodule. Now, how is it investigated? X-ray. In X-ray, there's what? Narrowing of the joint space and what? Osteophytes. Remember, I told you in rheumatoid arthritis, you have erosions, while in osteoarthritis, you have osteophytes. Osteophytes are abnormal projection or bony growths. Okay, and there's also reduction of the space. Both have reduction of the space, but for osteoarthritis, there's what? Erosion, while for rheumatoid arthritis, there's erosion. Osteoarthritis, there are what? Osteophytes. That is newborn formation and roughness. Okay, there is sclerosis of the underlying bone and cyst formation. Blood tests, ESR, blood counts are normal. Remember, in rheumatoid arthritis, what happens? The blood counts, the white blood cell count will be elevated, as well as the ESR will be elevated. The synovial fluid, when you aspirate synovial fluid, the white blood cell count in the synovial fluid will be normal because it is not an inflammatory autoimmune disease. Okay? Now, don't forget, I told you the treatment here of most of this joint pain, all these joint conditions are, their manifestations are pain, okay? So analgesia and rest usually are very important. Okay. Now, in case you are doubting if it is osteo, now, who can answer this? You have a patient, you are doubting whether it is rheumatoid arthritis or osteoarthritis. What will you do? Which investigation? If you have to do one investigation that will differentiate them, which one will you do? Yes? Who has not spoken today? Khadija. Khadija, were you in the lectures yesterday? Are you with us? Is it Khadija or Khalifa? Khalifa. Khalifa, you were not in the lectures yesterday. So, Sauda. Sauda. Yesterday,
Yes, sir.
you were not in the class yesterday.
I was.
But I was calling you yesterday, you were not responding. So
My
that
network.
what one investigation will you do that will differentiate osteoarthritis from rheumatoid arthritis?
Sir,
What one investigation will you do
for
that will differentiate both? If you have diagnostic dilemma, you want to do one investigation that will differentiate both.
rheumatoid
You said
that will differentiate between
rheumatoid arthritis from osteoarthritis.
I'll do rheumatoid factor.
I can't hear you. You do the rheumatoid.
Okay, I'll do anti-nuclear antibody.
Yes, anti-nuclear antibody or rheumatoid factor acid, because
Yes.
if it is osteoarthritis, they will be normal because it's not an autoimmune, it's a degenerative disease. So the anti-nuclear antibody and rheumatoid factor will be elevated in rheumatoid arthritis. So the treatment conservative, as we mentioned, okay, rest, physiotherapy and all that. The drugs NSAID. You can do intra-articular injection of corticosteroid. Physiotherapy is very important. Okay. The next form of joint pain we'll talk about is gout, gouty arthritis. Now, this gouty arthritis results from excessive deposition of uric acid metabolites, that is the sodium urate in the joints. Abnormality in uric acid metabolism resulting in the deposition of sodium urate salts. Okay, and there are some triggers. You see, all those products like meat product, beef product that will generate a lot of urate in the body will trigger the gout. That's why you see them avoiding things like meat. The risk factors: when a patient has impaired renal function, the excretion of the urate will be reduced, and so their symptoms will increase. Renal failure, Down syndrome, lactic acidosis, like patient that takes alcohol, okay, and when they exercise a lot, and they have the gout, it can trigger the pain in them. Okay, toxemia and pregnancy, polycythemia, and all these other conditions. Now, you have to do synovial fluid aspiration. When you do synovial fluid aspiration, you will see a lot of uric acid there. Okay, there will be elevated urate crystals in the synovial fluid examination. Even the serum uric acid will be elevated. Okay. Now, if you evaluate the synovial fluid, don't forget when you are doing synovial fluid evaluation, you are also checking for the cells. Okay, cells. Remember, if it is rheumatoid arthritis, you have elevated white blood cells more than 2,000 per millimeter cube. In osteoarthritis, the cells are normal. In gouty arthritis, they are also markedly elevated, okay, of more than 50,000. Now, the X-ray will show reduction of the spaces as well as punched out erosions. Now, usually the attack are unlike. Now, what differentiates the presentation of this and osteoarthritis from rheumatoid arthritis, this pain comes in attack and it is sudden in onset, unlike osteoarthritis that is gradual in onset. If you remember, I said the onset is gradual in rheumatoid and osteoarthritis, but here it is sudden in onset and it occurs in middle-aged and elderly people, unlike the rheumatoid arthritis that occur in much younger people. Now, for here, the sex predilection, it is commoner in males now in females. You remember which one is commoner in females? Rheumatoid arthritis, 3 times commoner. Osteoarthritis, equal. Gouty arthritis, more in males than in females. Now, so the treatment, you use NSAIDs, colchicine, steroid, analgesic, bed rest, okay? Glucosorrheic drugs for lung therapy and allopurinol. These are drugs that bind to uric acid, that reduce the amount of uric acid. So, in summary, if you look at gout, it's a disease that is caused by deposition of urate salt from abnormal uric acid metabolism, okay? And it is commoner in males than in females. And they present with sudden attack of pains in the joints, swelling and deformities. And of course, when they have triggers, and the risk is more in those patients with decreased renal excretion, which will cause more accumulation of urate in the blood. And when you do synovial examination, you have elevated uric acid, urate salts, and there's white blood cell increase. And the joint space, there are punch out erosions and reduction in the joint space. The last one we'll take regarding the joint today is the pseudoarthritis. This is seen in much more older individuals, and this is also deposition of crystals. There are crystal-induced arthropathy caused by deposition of calcium pyrophosphate dihydrate in the joints. Calcium pyrophosphate dihydrate in the joints. The actual etiology is not known, but is associated with hyperparathyroidism, hemochromatosis, hypothyroidism, and true gout. It occurs in 60 years and above, commonly affect the knee joint with sudden pain and swelling. This one, like gout, also presents with sudden onset. Other joints are the wrist, ankle, and shoulder. Okay, joint is warm, swollen, tender, and erythematous. Now, fever is common in the patient. Now, how do we investigate the patient? Then serum calcium and uric acid is done. Okay, ESR is elevated. Now, when you do the serum aspirates, synovial fluid aspirate, you have elevated calcium pyrophosphate dihydrate in it, unlike gout. When you do aspirate in gout, it's the urate crystals you find. And here also, aside the calcium pyrophosphate dihydrate, you also have elevated white blood cell counts in the fluid. So treatment, rest. You can see rest is very important in all joint lesion. NSAID, aspirate fluid, and inject corticosteroid. You can use colchicine for prophylaxis. Mark you, all these colchicine are not used in acute attack. They are used to prevent further attack. Okay. So any question before we proceed? Yes, any question? Any question? You don't have question.
No, sir. Yes, we don't have this.
So let me proceed. Now, this one is bullous pemphigoid. Okay, most common immunobullous disease. They are antibody-associated disease. Antigen antibody binding initiate complement activation and inflammation. Okay, it's also an immune disease. Okay, there's hemidesmosal damage and consequent subepidermal blistering. Okay, so it's a autoimmune disease and that is antigen antibody mediated activation of the complement cascade that will now cause subdermal damage of the skin, which will now cause this bullous, a lot of bullae. And these bullae are itchy erythematous, okay? And they present with tiny rashes before becoming blisters that they look like burns. When you scratch them, they now become swollen like this. It's not something that is very common in our environment, so I'll not waste much time on this one. Now, vitiligo, you'll see some people having some whitish patches, okay, all around, especially around their orifices, like their mouth, around their nose, in their neck, some yellowish hyperpigmented patches. You see them very black. If they are dark skinned, then you just see yellowish patch somewhere around their mouth, their nostril, their neck, or in their body. Okay? So that is an acquired pigmentary disorder of the skin characterized by patchy hypopigmentation. It's also an autoimmune origin, and it's common in patients with thyroid disorder. It results from destruction of the melanocytes in the skin. So the autoimmune antibodies will destroy the melanocyte, the melanin producing cells in the body. I know you know one prominent musician that has vitiligo. That is Michael Jackson. And because of this, the skin of the color of his skin, he has to do some form of modification of the color of his skin, but he actually had this vitiligo that covered all his body. Okay, it's an autoimmune and it's acquired. It's not something that a patient is born with. No, they grow up to discover, they'll just develop the disease and you just see the color of their skin just start changing. So that's why most of them have to now use cosmetic camouflaging to cover all their body with colors that will mask all those hypopigmentation. So how do they present? Generalized vitiligo often symmetrical and involves the hand, wrist, knees, neck, and areas around the body orifices. You see, some people will just have it around their mouth. You just see their lips whitish, while they are black skinned people. The hair. Now, sometimes when around those areas that are hypopigmented, you see the hair in those areas will become white. Maybe if they have vitiligo on their head, the hair around that patch will be whitish. If it's in their bed, they have it, the hair around that area will be whitish. Okay? Now, there's segmental restriction to one part of the body, but not necessarily a dermatome. Okay? Just take any form, not along the dermatome. Now, once you see those people that have leukotrachea, that is whitish hair along those hypopigmented patch, or they have multiple colors. It is called either trichrome pattern, when they have tricolor, that means it is an active disease. Okay? It's not a good prognosis. The disease will be progressive. Those people that you see, when you look at their vitiligo, you see an area that is completely white. Okay? And some area that is just maybe brownish, it is not completely white, and then the dark skin. It means the disease is actively progressing. It's at the active stage. It's not a good prognosis. Or when you see whitish hair growing around those hairy area, that is leukotrichia. So the absence of leukotrichia and trichome pattern are good prognostic feature. Now, how do you investigate it? Using wood light examination. Wood lamp or wood light examination is a kind of light, wood light. When you shine the light over the area that has vitiligo to make it more prominent, even if it's not showing, and will be more useful in patients that are not dark skinned. Of course, if you are black and you have vitiligo, it will be very obvious even from far. But if you have a fair-skinned individual with vitiligo, you might not even see it. As the case, though Michael Jackson had a lot of it in his body, that's why he has to find a way of camouflaging all by using cosmetic or bleaching all his skin. But he was not like that initially. So if you have somebody that is white skin or light skin, you might need this wood lamp, okay, to reflect on the body, and it will show the prominence of the patches. Okay, sometimes you might take biopsy, which is not even too necessary all the time, to demonstrate absence of melanocyte. The treatment, you have to avoid the triggering factors, like you don't have to be entering sun, avoid sunburns, which can worsen the vitiligo. Then you can use cosmetics to camouflage it. You can use corticosteroid, but the bottom line, you should know that it doesn't have cure. Okay, you can use phototherapy to reduce, and laser therapy. Okay, depigmentation, autologous melanocyte transfer. Some people, you just see it progressing, evolving everywhere in their body. Now, the next slide is on Kaposi sarcoma. Kaposi sarcoma is a spindle cell tumor derived from endothelial and immune cell infected with herpes virus type 8, HHV8, also known as Kaposi sarcoma virus. Now, this Kaposi sarcoma, what comes to your mind? The patient you see with this disease is HIV/AIDS. Patient with AIDS is one of the terminal signs, AIDS-defining illness. Any patient with Kaposi sarcoma, he has developed AIDS, and it's one of the terminal AIDS-defining illness. You know, there's difference between HIV, which is just the virus infection, and AIDS. When somebody has AIDS, he has gone to the terminal stage of the disease. And when you start seeing things like Kaposi sarcoma, that means the patient has developed AIDS. So it's one of the diseases that is related to this virus. And the various types could be epidemic, that is AIDS-related Kaposi sarcoma, iatrogenic, immunosuppressant therapy, patient that are on immunosuppressant drug. Don't be surprised, these intravenous drug abusers or steroid users can develop Kaposi sarcoma. They inflict it on themselves. Then classic or sporadic is rare. It could be epidemic in Africa. And these epidemic type are more aggressive. Now, how do they present? There are lesions. Kaposi sarcoma may involve the skin, they may involve the oral mucosa, they may involve the lymph nodes or even the visceral organs inside the body. Most patients present with cutaneous disease. The ones we see commonly is in the skin, and where in the skin, the lower limbs. You just see some ugly looking rash in the skin of the legs. Okay, dark patches, elevated rashes on the skin of the legs, lower limbs. Okay, lesion may be macular, papular, nodular, or plaque-like. Okay, they could have odynophagia, difficulty in swallowing, dysphagia, okay, abdominal pain, bleeding, GI bleeding, bowel obstruction. Now, you do their CD4 count, you have to screen them for HIV, do CD4 count, viral load, do X-ray, take a biopsy from that lesion. The treatment, of course, is antiretroviral drug, the topical retinoid, chemotherapy, radiotherapy, and excision. Okay, this one, acne vulgaris, we commonly call pimples. You can see this is common in your exams. Okay, it's a common chronic inflammation of sebaceous units, that is hair follicle, and their sebaceous glands. Now, what is pimple? What is remarkable about this is the black head. Okay, hallmark is the comedone, which is the open black head or the closed white head. And you see one thing about this, if you keep on removing the black head, it tends to get infected and become worsened. Now you have inflammatory papules, nodules, or cysts may arise from the comedones, and scarring may follow. Okay, and if you keep on itching it, it will become bigger, and it can even form keloids. You'll be surprised. Patient with keloids may just start from just simple acne vulgaris. Okay, it's affecting mostly the face, the back, and the chest. The one that affects the chest and the back usually is because of heat. Okay, and you have too much hypertrophy of the sweat and sebaceous, and blockage of the sebaceous gland. Okay, and they become infected. Most severe in the late teenage years, but can persist into 30s and 40s, particularly in females. Now, the causes are excessive sebum production from any cause, maybe due to excessive, the type of dressing you are using that will cause so much of heat that will lead to too much oily skin, okay, that will cause blockage of the hair follicle. They can cause pimple, okay? Now, one of the important things you need to know is the organism that causes it, okay? Colonization of the pilosebaceous ducts, okay, by Cutibacterium acne. That is the organism that causes it. And there is progressive inflammation and follicular hyperproliferation of this and subsequent plugging of the hair follicle. Some people may not have any cause, it may just be genetic. When you see patient with this, you can do hormonal assay, you can culture, take swab for culture, and you now give relevant antibiotics, as well as lifestyle modification, the kind of clothing, okay, and the kind of maybe creams they apply on their body. Okay, the next one here, I think we are going to stop after, because time is, we have just 6 minutes to go, 8 minutes to go. So let me just rush these few slides. This one is called pityriasis versicolor. I know most of you call it eczema, skin eczema, pityriasis versicolor. It's a common benign superficial cutaneous fungal infection. Okay, it's a fungal infection. It is caused by a fungus called Malassezia furfur. Pityrosporum. It's an organism that is commonly found on healthy skin, a region with cutaneous disease. It's present as hypopigmented or hyperpigmented macules. You can see this lady, all her back. It's common on the back or the chest of individuals. So it's commonly seen in the trunk. And most of these fungal infections, with good light examination, they become more prominent. Now, how do you investigate them? You scrape and take for histology. You see the organism there. Okay. How is it treated? Of course, you can use selenium sulfide, applying directly 2% ketoconazole shampoo and topical antifungal. In severe case, you can use oral antifungal like oral itraconazole treatment. The next image here is called hairy leukoplakia. If you look at this man's tongue, by the side of his tongue, you can see some whitish hairy plaques. A white corrugated hair-looking lesion typically found on the lateral border of the tongue. The pathology is associated with Epstein-Barr virus, strongly associated with immunosuppression. The risk factors include HIV infection, organ transplant, other immunosuppressive diseases, oral topical inhalers. The treatment, you use antiretroviral therapy, okay? When you see hairy leukoplakia, remember Epstein-Barr virus. And when you see the image, it's on the lateral part of the tongue, not on the dorsum or on the ventral surface. Okay, the next image here is alopecia. That is hair loss. It's a common non-scarring type of hair loss that can affect hair-bearing area, alopecia areata. Well-defined, localized, non-inflammatory, non-scarring patching of alopecia. Pathognomonic of exclamation mark. Okay. Diffuse pattern can uncommonly occur. Nail pitting may be present. Okay. Alopecia could be familial in 20%, associated with Down syndrome. It could be immunological. It could be associated with vitiligo. It could be associated with psychiatric disorders. Some patients will be plucking their hair. And those patients that pluck their hair, some even swallow it. And it will cause intestinal obstruction. And you'll start having abdominal pain. That is called bezoars. It is called trichobezoars. They pluck their hair and swallow it to go and block the intestine. That is called bezoars, trichobezoars. Sometimes they come with intestinal obstruction that will require operation. Now, diagnosis is usually clinical, okay? Scalp biopsies seldomly needed, okay? Treatment, psychological support treats underlying cause, okay? Okay, I think we are going to stop here. We still have a lot of slides. We have over 200 slides on this image. So when it is just time, we are going to stop. So do you have any question? Any question? Okay, there are 183 slides. So today, I'll rather stop at this hairy leukoplakia. That is slide number 15. Then we'll continue from there next time. Yes, any question? Are we together?
Yes, sir, we're together.
Any question? Who is your group?
Sir, please, can you?
Yes, you wanted to ask?
Yes.
Yes, go ahead.
So please, can you remind us the timing for the morning stiffness for rheumatoid arthritis and
Can't hear you.
osteoarthritis?
You said?
Can you please can you please remind us about the time for rheumatoid arthritis and osteoarthritis? Like I saw a question that was saying one is 30 minutes and the other one is it more than 1 hour?
Your
So I
voice.
wanted to please
Speak clearly, I can't hear you.
I was talking about the rheumatoid arthritis and osteoarthritis.
Okay,
I
what
said,
about that?
can you please tell us the time?
I showed you the signs now.
No, not the signs, the time, the difference between the timing.
Timing.
The time, like one says it's I can't remember, but I saw a question that was
Type
saying
your
30
question.
minutes,
Type your question. You don't have
30 minutes.
Okay. She's asking about the time. What do you mean by time? I said osteoarthritis and rheumatoid arthritis occur gradual. They have gradual onset. Okay. While gouty arthritis and pseudo gouts have sudden, their occurrence occurs sudden in onset. Then the age for rheumatoid arthritis, they occur in younger individuals that are less than 50 years, from 25 to around 40, but less than 50 years. Then osteoarthritis is a degenerative joint disease. It occurs in people that are more than 50 years. It's degenerative. It has no sex predilection. Unlike rheumatoid arthritis, that is 3 times commoner in females than male, osteoarthritis has equal sex preponderance. It's the same. While gouty arthritis, they are commoner in male and they are seen in over 60 years. More elderly people. Okay. Okay. I'm asking about the timing of difference. I saw, no. It's about just early morning stiffness. Because if you say timing, you will confuse me. Just ask about this early morning stiffness, okay? The early morning stiffness in gouty arthritis is more than 30 minutes. Okay, they will have, when they wake up in the morning, the stiffness will be there for up to an hour. The joint will be stiff for more than 1 hour when they wake up in the morning. That is for rheumatoid arthritis. Why for osteoarthritis is less than 30 minutes? That is what you are asking.
Yes, sir.
Yes. So it's
Thank
about
you.
the early morning stiffness. For rheumatoid arthritis, it's longer because it's autoimmune. The reason being autoimmune, it takes time for the system to clear the antibodies, but this is just the generation of inflammation. That's why. Any other question? Yes, any other question? Okay, it's 10 o'clock. What lecture do you have tomorrow? What lecture? Do you have lectures tomorrow?
Tomorrow, yes, we do. Placenta.
What lecture?
Placenta.
Oh, you are doing 1G now?
Yes.
Okay, that is good. So we'll try as much as possible to cover a lot of things, even on the online lectures. Aisha, where's Aisha Hadi?
I'm here, sir.
You are coming to collect your book tomorrow by 5 p.m. Okay. So thank you all. We are going to stop here.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, sir.